going to talk about the PRoFLUID study. It was a practice of fluid therapy in critically ill, invasively ventilated patients. So, fluid therapy is the commonest thing we do, I think, in the ICU, generally in hospitals, generally speaking. And but since time memorial, or since way back, we've known that we've been using fluids over and over and over again. And then, of course, the issue of, is fluid medicine, is it just fluid, comes up. So we know that liberal strategies now and positive cumulative fluid balance is associated with worse outcomes, especially in ARDS and septic patients. It has also, as time has moved, we have now also realized that restrictive strategies and early deresuscitation shows benefit to our patients. So we now know better than to just go pouring fluid in any patient we get. It's also now being studied, and we know now that early vasopressor initiation can prevent fluid overload. So instead of pouring fluid into your patients, you can start your vasopressors a bit earlier, because usually our goal while we're managing our patients is for hemodynamic stability. So you put in your vasopressor, so it helps you reduce the amount of fluid that you're going to be giving them. So generally, global variation, of course, high income, low income, middle income, we definitely expect differences. So the current global fluid practice is poorly characterized, and this is the gap that the PRoFLUID study came in to try and fill out and answer some of these questions. So it was an international prospective cohort between April 2024 and July 2025. It involved 206 ICUs over 41 countries across 6 continents. And they were taking in invasively ventilated patients. That means patients who received invasive ventilation for over 24 hours within the first 3 days of admission. And the outcomes were looking at fluids in terms of what kind of fluids are we giving, how much fluid are we giving, what is the composition, are maintenance fluids being given more than resuscitation, in that kind of way. Then vasopressor use, diuretic use, the fluid balance, and then associated outcomes, especially mortality. So this is just a map to show you the extent of the study. Of course, heavily representative, predominantly Europe and Asia. So Uganda, in the PRoFLUID, we had 13 patients recruited in 6 ICUs. About 27 were enrolled. Of course, the registry came hand in hand with this. So the sites that were involved, ICU, the registry in Uganda, site 333, 336, and those are the details of the patients who are recruited and the data completion in terms of percentages. So the PRoFLUID study has not yet been published, but when they do publish, we shall know more about it. So while the PRoFLUID was going on, there's a parallel study in Uganda titled Early Cumulative Fluid Balance and Associated Outcomes Among Critically Ill Patients in Ugandan ICUs. This was done by yours truly. I'm yet to defend it as my MEd. So just a small peek. It's a prospective multi-center cohort. It included 3 ICUs in Kampala. We had Nsambya Hospital representing PNFPs. We had Mulago Hospital representing the public sector, and then Nakasero Hospital representing totally private for profit. We managed to enroll 227 patients. No, we managed to analyze 227. We enrolled over 250. So the exposure was just, basically we were taking on patients who had been in the ICU for more than 72 hours. So we needed them to have a 72-hour cumulative fluid balance. And the outcome would take 28-day ICU mortality or discharge or whatever happens by day 28. So why does this matter alongside the PRoFLUID? So for the PRoFLUID, they only concentrated on the invasively ventilated patients. While this study, we took all critically ill patients, whether they were invasively ventilated or not. So it would be a good thing to kind of just put them together and see what the Ugandan picture is. So in Ugandan ICUs, this is what I found when we're doing the study. We have 89.8% having positive fluid balance by the 72-hour mark. And the median 72-hour cumulative balance was positive 2.1 liters across the board. ICU mortality at 28 days was 30.8%. I'll let that sink in for a few minutes. So, I don't know if you're thinking we're doing well. I don't know what you were expecting, but this is what the findings were. So, Uganda's median, like I said, 2.1, which is below what would call the Libro overload of about 7 liters is where they say you're doing the Libro approach. But at the same time, it is above what would be calling the restrictive benchmark, which is the 1.5. So are we doing so badly? Are we restrictive? Are we Libro? I'll leave that to you. So fluid balance did not independently predict mortality after adjusting for the confounders. So that's the adjusted odds ratio of 1.03 with a p-value of 0.6. So survival was mostly driven by respiratory support. So in Uganda, patients who are managed non-invasively had a lower chance, 70% lower odds of death, as opposed to those who receive invasive mechanical ventilation. Hospital setting really mattered. Institutional factors were independent predictors of the outcome. Details will be in my final presentation, but this is what is coming next. So, PRoFLUID is yet to be published in JAMA, and when that happens, we shall have a full Uganda PRoFLUID analysis when the international dataset is released, and then we'll have the combined Ugandan dataset. That is my study plus the Uganda PRoFLUID cohort, and then we shall together have the most comprehensive fluid therapy dataset from Ugandan ICUs to date. Thank you very much.